I am a physician and public health nutrition advocate. I work as a Chief Health Equity and Wellness Officer for Cape Cod Healthcare. And today's program, we will have it as two parts. First, Dr. Aaron Dickstein, who's next to me, will be speaking on early detection and screening. And the second part, I'll be speaking on nutrition and prevention for colorectal cancer. Before we start the program, I just want to give you some basic details. We have a chat box that you can see where you can type in the questions throughout the program as questions come to your mind. At the end of both our sessions, we will go through the questions in a Q&A session. And the slides from today's presentation will be available. It will be posted to Cape Cod Healthcare's website, I would say a week from now. And the website is capecodhealth.org/colorectal-cancer. That is capecodhealth.org/colorectal-cancer. And as I said, even if you miss out on today's questions, you can always reach out to us with questions after the fact, after the session, by emailing us to outreach@capecodhealth.org. So with that, I would like to hand it over to Dr. Aaron Dickstein, our gastroenterologist of Cape Cod Healthcare, practicing in the hospital for procedures and caring for patients, also in the outpatient in Hyannis. So Dr. Dickstein, some thoughts, yes.
All right. Well, thank you all for joining us today. I'm excited to give this talk about colorectal cancer screening. And I think it's going to be a good evening. Let's start. Just to let you know, a lot of my talk is based on the American College of Gastroenterology's 2021 guideline for screening. And you can go to their website. I'll post it at the end for you all. There's a lot of patient-centered information regarding colorectal cancer screening if you don't get enough tonight. My goals for our talk tonight, we're going to talk about screening and how, particularly in colorectal cancer, screening is actually preventative rather than just an early detection device. We'll talk about a colonoscopy, and I will spend a little time on talking about the preparation because that's one of the big questions people want to know about. We'll talk about what a polyp is and why it's important to find these to prevent colon cancer. We'll talk about who is at risk for colorectal cancer, and I'm going to give you a spoiler alert now. Everyone is basically at risk, so that's why we do universal screening. We'll talk about some of the signs and symptoms of colon cancer. Again, another spoiler alert here. Early colorectal cancer, there's often no signs, so that's why it's important to be screened. We'll talk about screening options. I'll talk a little bit about the pluses and minuses of the stool tests. And then we'll talk about when to screen average risk people as well as people with family history or at increased risk. So let's go. So yes, so to start, many of you know of other cancer screening tests, prostate cancer with the PSA, breast cancer screening with mammography. And in those tests, really what you're trying to find is early cancer so that you can treat it early and have hopefully a good outcome. In colorectal cancer screening, it's different. We're trying to find polyps and actually prevent you from developing cancer. So it's a unique type of screening test. So yeah, I'm going to repeat it a few times just so the audience can take it in. You can prevent, not just detect colon cancer with a colonoscopy. When we remove these precancerous growths called polyps, we reduce the risk of future colorectal cancer. And it's felt somewhere 80 to 90% of colon cancers can be preventable if people follow the screening guidelines. So that's basically why we're having this talk tonight. And hopefully, if your friends or colleagues or family aren't listening, you can spread the word to them as well. So just to go back to biology class a little bit for you guys from high school, the large intestine is the same as the colon, and this is a pictorial of the colon itself. Just to point out a few things, you see the rectum is at the bottom there, then we go to the sigmoid, descending, transverse, ascending, and cecum are the two different parts of the colon. You can see the appendix at the top there, and why that's important for us when we do colonoscopies. How do we know we've seen the whole large intestine? We look to see the appendix, and when we see that opening part of the appendix, then we know we've reached the top of the colon, we've seen it all, and so hopefully we won't miss any polyps and such when we're looking. I mentioned the rectum just in particular. I know you might have heard that in younger people, we're starting to find more cancers. One of the reasons why the screening guidelines have lowered the first date to 45 years old to get them. We're finding a lot more in the rectum with the young people. Still pretty rare, but it's just an interesting phenomenon that we're still trying to understand at this time. But I just wanted to mention that part of the anatomy to you. So we'll talk a little more later about it. And so let's go to the colonoscopy day, a little tutorial for you all. I'll say the day actually starts the day before your colonoscopy. On that day, you're going to be on a clear liquid diet. So you can get some of that roughage will be easier to pass through because you're not taking it in that final day. The night before, you'll drink a solution and you're going to have diarrhea. You're going to clear out that colon. The morning of the test, you do another bit of that solution and again have the clearing sort of the laxative effect of the medication. And again, the goal is that your entire colon is clear of stool so we can see. Then you come into the endoscopy center or the hospital for your procedure. On that day, you'll meet the anesthesia provider, you'll meet the nurses, you'll get an IV put in, you'll get sedation through the IV for the procedure, so you're nice and comfortable. The procedure itself takes somewhere 15 to 20 minutes, maybe a little longer, depending if you have more polyps or not. And the medicine we use is quick on, quick off, so it's a pretty it's not a deep sedation where you have a breathing tube and stuff. It's a pretty light sedation, but you're still comfortable throughout the test itself. And then once you're comfortable, we do place a tube with a flexible tube with a camera at the end, and we look through your whole large intestine, trying to find polyps. Again, we'll talk more about what polyps are and what they mean, but that's the basic process of the colonoscopy. Now, everyone asks and everyone wants to know, why do I have to drink the preparation? And that's, I think, one of the reasons people are afraid or hesitant to do a colonoscopy. And I like to give this analogy. I'm basically driving on the road of your colon, and I'm trying to find polyps, these growths that could become cancer. So as we all know, if you're driving on a nice sunny day, it's very easy to see any polyps that might be in front of you. And then you see them, you can remove them. If you're driving on a snowy day, there's snow, the windshield's clogged, you can't see. And so when I'm doing your colonoscopy, I want to be driving on a nice sunny day and find those polyps versus, be stuck in the snow. And as you might guess, during a colonoscopy, it's not snow that I'm stuck in. So, it's very important to do a good preparation. I'll leave it at that. So, and here's the process. So where does colorectal cancer start? So we think it starts for the majority of colon cancers with a polyp. So you start at a small growth on the lining of your colon. It becomes small or large as we call adenomas, which is a little bit of abnormal tissue. That then can become what's called dysplasia, which is more abnormal tissue, kind of on the road to colon cancer. The polyp itself could have cancer cells in it, but not yet spread beyond the first wall of the lining of the colon. And then when it spreads beyond that, that's when we think of the cancer that's certainly more of a problem. So our goal when we do our colonoscopy is to find the small polyps before they've progressed to dysplasia, cancer inside the polyp itself, or cancer that's spread. We think this process takes somewhere in the 10-year range, and that's why if you were to have a normal colonoscopy on your first one, we wait 10 years to your next one because we think we have time to look for these polyps. So polyps come in different sizes, and just some examples here for you. You can see in the top right corner, that's what we call a pedunculated polyp with a little stalk on it. And then we have some that are very subtle. You can see in the bottom right corner there. The growth that's on the bottom left corner, that's a bigger polyp that has sort of indentation in the middle. I'd be concerned that that's actually colon cancer or getting close to that. But these are all polyps that we find during colonoscopies there. And for the most part, we can remove them during the time of the colonoscopy. And some polyps are harder to see. And you can tell some of these polyps they look just like there's mucus covering them, but that's actually a polyp underneath. There are some that are just the same color as the lining of the colon itself, so you really have to look carefully. And we have some special techniques that we can use to change the lighting. And you can see here, let's see if it won't show you with a pointer, but some of the polyps, it looks like it's just small little polyps like the one in that A bracket, but actually it's a much larger area that I would remove during your colonoscopy to remove totally that polyp. And I have a video for you. This is one of my colleagues in New York who recorded this video for the American College. So here you can see we're coming back in the colon lining. We're looking carefully, and there's a polyp at the bottom there. So we identified one. We're about to remove it. So we're going to put a small metal, kind of a lasso out that comes through the port of the scope. We get around it, and we're going to use a little cautery, and he's going to burn that polyp off. You'll see that. So now the polyp's burnt and removed. And then we go up to it, and we can suction it through the scope. So now the polyp is completely removed, and the nursing team will be able to grab that, and we send that to pathology. And then we're just clearing it at the end here to make sure all of it's removed. And you can see, because we use cautery, you can tell it's hopefully not going to bleed in the future. And you can see those little purple fingers that are coming out. That's a device, it's a cap at the end of the scope that allows you to pull down the mucosa lining so you can see well as you reverse. And I use that kind of cap often with my colonoscopies. And there you go. So that's one polyp in that person's colon, and there may be more, of course. Okay. See if I can move forward here. Perfect. Okay. So now you saw how we find polyps, how we remove polyps, and let's talk about what the risk of colorectal cancer is. So, these change a little bit, but the lifetime risk of colorectal cancer in men is 1 in 23, and women 1 in 25. So that's pretty common. And we're seeing that those born later, so the millennials born in 1990, actually have an increased risk of colorectal cancer compared to those born in 1950. And this is what I was mentioning earlier. This is something that was a huge area of research and concern that we're finding these. And one of the reasons why our screening guidelines have changed to 45 as your first colonoscopy instead of 50. And you can see, as I was mentioning, there's 4 times the risk of rectal cancer in those born in 1990 compared to those born in 1950. And we can get into some more of the thoughts or reasons why people think this is to be the case. And again, it's not completely understood yet, but we do think there's some environmental exposure that could be contributing, perhaps partially nutrition and obesity, which we're going to hear about a little bit later, maybe some forever chemicals or things that people are exposed to. But this is a area of active research. And we'll talk about other risk factors now. So if you have a family history of colorectal cancer, that's especially true if it's a first-degree relative. So a parent, sibling, or child aged less than 60 who has a diagnosis of colorectal cancer certainly increases your risk for it. Polyps as well can increase your risk. And if they have high-risk polyps, it's something you want to know about. Cigarette smoking, obesity, physical inactivity, inflammatory bowel disease like ulcerative colitis or Crohn's disease, those people we really screen carefully and watch closely. And African American race used to be an increased risk factor. Now we're finding that it's actually pretty similar, but in the past they had a screening guideline recommendation of 45 as well. So let's talk about symptoms in colorectal cancer. And like I said, most early colorectal cancers produce no symptoms. This is why we do screening for everyone. You never want to ignore any new or worrisome symptoms, of course. And if you have those, regardless of your age, it's important to reach out to your healthcare provider. Just a short list of some of these symptoms of concern: blood in the stool, change in bowel habits, change in the shape and size of stool, rectal pain, abdominal pain, and an unexpected weight loss or anemia. Now, any of these don't mean that you have colorectal cancer, certainly, but if you do have those symptoms, it's something you want to reach out to your healthcare provider about to be sure that the right tests are done. And so what do you do if you don't have any symptoms of colorectal cancer? You get screened, because screening means being checked even if you have no symptoms. Now, just talk briefly now about the types of screening. There's the 1-step versus 2-step screening for colorectal cancer. So when we think about 1 step, we think about looking for polyps. We think about a colonoscopy. And so we're looking for polyps in the entire colon and rectum. You can detect and remove them. It's the most commonly performed GI procedure in the US. And the thought is that colonoscopy with removable polyps offers long-term protection against developing colorectal cancer or dying from it. So, of course, that's my bias. I think colonoscopy is the best way to be screened. If you're going to choose nothing or using one of the stool tests, I do think the stool tests have some value. And the two most common are the FIT, the fecal immunochemical test, and the multi-target stool DNA test, which is known in the US as Cologuard. And so these tests are looking for, the FIT test is looking for pieces of blood in your stool that could indicate, there could be colon cancer. And Cologuard looks for both, is the FIT test, plus it's looking for DNA fragments that could suggest that there's a high-risk polyp or colon cancer. And these tests are very good for finding colon cancer. So 90+% of people with colon cancer will test positive on these tests. So they're a good cancer detection test. But those high-risk polyps I was showing you earlier, if you have those, only 40% of people will test positive with these stool tests. So when you're thinking about a cancer prevention test, the stool tests, I would say, are not quite there yet at being ideal for this. Not to say that sometime in the future they might improve to that point, but for the moment, they're not as ideal. I will say that the most important thing if you're going to choose a stool test is that if it's positive, you go on to get a colonoscopy. And the statistics we have in the US, only 56% of people who have a positive stool test go on to get a colonoscopy. So this is a big sort of problem I see in this testing modality. Let's talk a little bit about the screening recommendations now. So now, like I was mentioning, for average risk individuals, people with no family history, the age to start is at 45, and you continue screening based on what you see up until age 75. Once you hit the 75-year mark, we personalize the decision. So if you're a very healthy 78-year-old, we might offer screening tests at that point. If you're someone who is healthy but had a normal colonoscopy at age 50, normal colonoscopy at age 60, normal colonoscopy at age 70, and no family history, we may not do another colonoscopy at that point because you've shown yourself to be low risk for developing these problems. So that's what I mean by personalized. And our American College of Gastroenterology recommends colonoscopy or FIT testing as the primary methods, in that we have the most data for those two tests as being cancer preventative. Now, if you have a family history, this is where it becomes important and where I'd encourage you all, if you're sitting with family members or going to a family gathering soon, you have to ask the question, ask your family members, have they had colon cancer? Have they had a polyp in the past? Because you need to know this information. But really, it would start at age 40 or 10 years earlier than the cancer diagnosis, whichever is earlier. So if you have a father with colon cancer at 55, yours would be at 40. If you have a father with colon cancer at 45, yours would be at 35. Hopefully that makes sense. You want to repeat the colonoscopy at a shorter interval because of the family history, and that's important. And if you have genetic predisposition or genetic testing, it might alter these recommendations. And so when you want to get a test screen, that's when you want to reach out to your primary care doctor, and they'll refer you or order a stool test if that's your preference. And so I would encourage everyone who's in that screening guideline time period and they haven't yet had theirs to reach out to their primary care doctor. And finally, I'm just going to finish with some excuses that I've heard, and I want to answer those excuses. I think you guys are ready. Here we go. Your excuse to avoid a colonoscopy, I feel fine. And as we mentioned, colon cancer, colon polyps develop silently without any symptoms. So if you wait till symptoms, that means the cancer could be more advanced and less likely to be cured. Your excuse to avoid colonoscopy, I'm healthy. Why get screened? Well, colorectal cancer screening is for healthy people. If we find a polyp and remove it, we can prevent it from becoming cancer. No one in my family had colon cancer. Well, don't be the first. Like I said, roughly 5 in 100 are destined to get colorectal cancer in their lifetime, even with no family history. Your excuse to avoid colonoscopy, I have no risk factors. Well, the single biggest modifiable risk factor for colorectal cancer is failure to be screened. So that's why we're giving this talk today, and that's why we're trying to promote it for everyone to understand the risk. Your excuse to avoid colonoscopy, only men get colon cancer, and I think I've described that already, that it's an equal opportunity disease and women have almost the same risk as men. So yes, I'd encourage everyone to get screened. Thank you for your attention today. And a little bit later, we'll answer any questions that you might have.
Thank you very much, Dr. Dixon. That was excellent, very thorough. It listed out for me personally when I'm looking at the slides from here. I saw that to be concise, thorough, and hopefully the viewers, you all took information from it that's valuable. And as I said earlier, you can type in the questions you have in the chat box, and we will get to the questions soon. So we're moving on to the next session. Where I'll be talking about the top 10 food strategies for a healthy colon. So we have, as you can see, we have the food that I'll be referencing to displayed in the table. And so the outline, I'll talk about dietary fiber and the importance of healthy, friendly gut bacteria, and a particular substance we'll focus on called butyrate. I'll come to that. I'll talk about antioxidants, second strategy. We'll talk about how to prevent DNA damage that can start a cell to become a cancer cell. And in that, we'll talk a little bit about animal protein and its role in creating a change, a harmful change called epoxide. I'll come to that in one of the slides. The lining of the intestines, how important it is, what we call as a mucosal barrier, or the lining of the gut, the importance of it, how to keep it healthy. That's a strategy we want to focus on. And how to boost the DNA repair mechanisms that our cells have, including our colon cells, to make sure that cancer doesn't set in. We'll talk about insulin-like growth factor 1 and the role of cancer and diet in that. And we'll talk about trigger foods to avoid inflammation in the gut, which can later on become cancer. And also in general, how to reduce long-term inflammation in the body in general by limiting excess calories. And I'll touch on immune balance and where it happens in the gut and the importance of that in keeping the colon healthy, and mindfulness in eating. So we'll just looking at this strategy 1 and 2, this is focusing on dietary fiber. Now, the dietary fiber is so important for the friendly gut bacteria, intestinal bacteria to thrive well. And these intestinal bacteria, they work on the undigested dietary fiber to produce products that are called short chain fatty acids. The commonest one is called butyric acid or butyrate, and that is like gold to keep your colon healthy. So for colon cells, it's like oxygen, you could say. Butyric acid, short chain fatty acids that are produced by the action of the gut bacteria on dietary fiber is going to be key. Now, the foods that have been shown to have the most effective production of this butyrate when the gut bacteria is working on them is beans. Beans and leafy greens have been shown in studies to have a high level of butyrate production. So that's something to keep in mind. And generally, dietary fiber, high fiber foods, fruits, vegetables, whole grains, legumes are important, but the beans and leafy greens are the top in the chart. Antioxidants. So antioxidants are, as the name implies, they go against the oxidants, right? And oxidants are those high energy molecules that are produced in the cells. And these are like bull in a china shop. They can knock around and break the DNA of the cells. And if you're talking about colon cells, then they can create a cancer cell by breaking the DNA. And because every cancer cell, it starts with a break in the DNA, what we call as mutation in scientific lingo, it's a broken DNA. And so in order to neutralize or put this bull in the china shop into sleep, we need antioxidants that actually donates an electron for these oxidants to make it quiet so that we can limit the damage to the cell's DNA, thus preventing a cell from becoming a cancer cell. And how do you supply enough antioxidants? Color. Color is our cue. Colorful fruits and colorful vegetables. So you could probably see the colors spread out here, leafy greens, even cacao that is used in dark chocolate, green tea, herbs and spices, or a variety of sources of antioxidants. So the number 3 strategy is, so let's say we have a lot of oxidants, these bull in the china shop floating around in the cells. They're gonna come and attach themselves to the nucleus of the cell and break the DNA, which we just talked about. So in order for them to get attached to the DNA, for them to break the DNA, there needs to be certain linkages that are called epoxide. So these epoxide linkages are excessively set in the cell when there is excess animal protein in the diet. So there's a connection between too much animal protein leading to these epoxide linkages that can connect the high energy, bull in the china shop oxidant to the cell's nucleus to facilitate this DNA breaks from happening. So swapping as many meals as possible, as much portion as possible from animal protein to plant protein can not only limit the this DNA breaks and these epoxide bridges. Also, if you think about it, we are swapping the animal protein with beans, as I said in the earlier slide. We are also going to have more of butyrate production, which is also going to be healthy for the colon. So, and number 4 is looking at how do we protect the lining of the gut. So the lining of the gut, we call it mucosal barrier. It has 5 layers to it. Each layer has significant protective functions that is happening, right from the first layer that has like a gel-like coating that can catch unwanted substances and prevent it from getting into our circulation, into our system. And then we have layers of bacterial layer. The friendly bacteria resides in that. We have our immune cells residing in that. So all these layers, when there is any break in these layers, that leads to a loss of protection, loss of a fine balance in our inflammation system, in our immune system that keeps everything healthy for the colon. So how can the lining be affected? When can there be a breach in the lining is when there is high fat content coming in or high sugar contents. These have been shown that higher fat diets and high sugar diets can affect the lining of the gut, the mucosal barrier we call it, which can lead to a shift in the immune balance. I'll talk about it in another slide, which can affect the friendly bacterial population, which we already talked about. Wow, how important the friendly bacteria is to facilitate butyrate production and keep the immune balance, keep the inflammation under check. So all of that is going to be important. So again, so reducing oil-based foods, animal fats, even plant fats in a higher amount of cooking oil, all of that is going to be harmful in this sense. And generally reducing sugary foods is unprocessed carbohydrates is going to be helpful to keep the gut lining healthy. So moving on to strategy number 5, how can we enhance the DNA repair mechanism? So we talked about cancer cells forming with a DNA break, right? The mutations we talked about. So first step is to make sure that there is not enough oxidants. So antioxidants is going to remove the oxidants that can break the DNA. If the oxidants are there, you don't want them to be coming and touching the DNA. So you want to avoid the epoxide bridges, limit the animal protein. And let's say the bull in the china shop is now broken the DNA, right? So there is a DNA repair mechanism that each of our cells have, including our colon cells. Every cell in our body has a DNA repair mechanism. So it's almost like somebody's shirt is torn and there is a tailor immediately sewing up the tear. We have that amazing capacity. Now, how can we boost this DNA repair mechanism is through substances called phytonutrients. These are plant naturally occurring nutrients or chemicals in plant foods that has been shown to enhance the DNA repair mechanism, so that if we have a cell that is beginning to turn into a cancer cell, we call it dysplasia, then immediately that DNA can be fixed so that it doesn't become a cancer cell. So phytonutrients are in leafy greens, in colorful berries, colorful vegetables, citrus, any of the citrus fruits, lemon in particular, and other citrus fruits, green tea with catechins in it, and then spices, many of the spices or high in phytonutrients. So these are things to be thought about when you're bringing in your weekly meal. So, and then the next one we'll talk about is the insulin-like growth factor, IGF-1. This grows tumors, right? So we know some of you who attended the previous breast cancer lecture that I gave on the wellness trails, we touched on groups of humans who have Laron syndrome, who have a genetic defect where they cannot produce insulin-like growth factor. They are immune from getting cancers. It is impossible for them to get cancers. So what do we learn from them is that when there is not enough insulin-like growth factor, they don't get cancers. What happens in the flip? When there is excessive insulin-like growth factor 1, then there is an increased risk of cancers and mortality from cancer. So that's been studied and shown. So animal protein increases blood levels of IGF-1. That's also been shown. So again, as I said, swapping more of the animal protein to plant protein is going to be helpful. So the dietary approach has multiple mechanisms through which it works. And that's what we're breaking down in the different strategies we're looking at, right? So it's going to be the same. We listed out 4 types of beans in these cans here, right? So they're coming into play through different strategies. It is stopping the epoxide bridges. It is providing more butyric acid with the action of the gut bacteria, and it is also reducing the amount of IGF-1 levels. Limiting trigger foods. So the International Organization of Inflammatory Bowel Disease are looking at how to reduce inflammation in the gut. They propose to avoid certain foods that they call as trigger foods, because this trigger foods can create inflammation in the gut, and an inflamed gut is going to be setting the stage for a cancer in the gut later on. So there are certain foods that are listed by this organization as trigger foods: red meats, artificial sweeteners, something called a myristic acid that is in palm oil or coconut oil or dairy fats that is irritant. Any emulsifiers, thickeners, some of these latest foods that have things like carrageenan, new things that are found, these things can be irritant for the gut. Titanium dioxide used for coloring foods can be toxic. Sulfites can be toxic. So these are things to be thinking about. So avoiding trigger foods is key. And then just generally minimizing long-term inflammation overall in the body. That's going to be important. How do we do that? Is by shutting off the sources of long-term inflammation in the body. One of them is something called visceral fat. It is also called abdominal fat. That is a fat tissue that is closely encasing or surrounding the intestines we have. And those fat tissues are different in their behavior compared to the fat tissue somebody may have just beneath the skin, right? So those are called subcutaneous, beneath the skin. These fats that are deep inside the abdomen behave differently, and they're the most toxic because they are like a plant, a factory producing inflammation. They put out inflammatory molecules. So how do we make sure that we don't have too much of a visceral fat? Is just not eating too much calories. Any excess calories we consume can be packed away in the visceral fat. And we know that inflammatory markers in the blood test can go up when there is a visceral fat. So making sure that your foods, you're not eating excess calories. You're also making sure that the food is not calorically rich and dense, and it's mostly nutritionally rich, nutrient-dense foods, like you're looking at here, the leafy greens, the colorful vegetables. Those are going to be at the top of nutrient-dense foods which are lower in calories. So thinking like that is going to be helpful as well. And coming down to the number 9 is about maintaining the immune balance. So whenever there is a change, a shift in the balance that the gut has in its immune power, that can lead to inflammation, which can lead to cancer. So what do we mean by balance in immunity? So we have immunity, and nearly 60% of our immune cells are in our gastrointestinal system, starting from the throat, where there are adenoids, all the way through the gut with what we call as Peyer's patches and spleen. So the gut system has 16% of our immune cells, right? And when you talk about balance in immune system, we need to have enough immune system to attack when they need to attack a virus or a bacteria that enters our system. We also don't want the immune system to be overreacting to anything that comes in. So that is called a lack of immune tolerance. So just attacking anything and everything, overreacting, that can lead to autoimmune diseases. It can lead to other conditions. We saw in situations where excessive immune attack can damage our own tissues. So how do you find that balance? Is there is a cell that's called T regulatory cells, Tregs shortly. These regulatory cells are the ones that say, hold the fire to our immune system when the immune system should not overreact, right? So these T regulatory cells, again, coming back to the gut bacteria and dietary fiber, having enough dietary fiber helps to have enough gut bacteria that are friendly to us. And having enough friendly bacteria, make sure that we have enough of the T regulatory cells that can rein in on our immune system's overreaction and attacking our own tissues like the gut. So, and that keeps the immune in a system in a balance, and that is helpful to prevent inflammation of the gut and long-term prevent cancer of the gut as well. So what we talked about for dietary fiber and gut bacteria applies to this strategy as well. And then I'm finishing up with mindfulness in eating. Paying attention to the body's signals as we are eating is going to be key to understand, okay, I'm no longer hungry. Now I can stop eating. As opposed to, oh, I'm uncomfortably full, and just realizing at that time, by that time, you have added excess calories, right? And that excess calories is just going to set in as visceral fat we just talked about. So, so that's going to be key, paying attention to the signals of the body, of the gut, and then knowing when to stop eating is going to be key. So savoring the food and listening to the body's signals and avoiding even like, multitasking, while we're eating, all of that is going to be something we may want to consider changing so that you can start to kind of start listening to the body's cues, avoiding overeating, and that can be helpful, and you will also enjoy the food better. So that is all we got today in terms of the 2 sessions. At this time, I know you've been sending questions, so keep sending the questions through the chat box, and we can start with a Q&A at this time. Yeah.
Would you like to take the first one? You want me to?
Yes.
This is. You want to start for you? Yeah.
Yes. So are probiotics good for your gut health? I would say generally dietary fiber, fermented foods is the best way to get gut bacterial production going in the gut. Relying on probiotic capsules is not the ideal way. It is not very scientific. The data is kind of mixed on probiotic capsules, when to use, how long to use. So I think the best way to go about is using fermented foods, sauerkraut, for example, tempeh, which is fermented tofu, miso soup, beans, blueberries. Those are called prebiotic foods, and that's a good way to start, jumpstart, and then starting to eat more wholesome foods like these. It's going to help with that.
I get that question a lot too. I agree with Dr. Siddhartha with that. Question for me, does insurance cover the cost for a screening colonoscopy? And yes, all insurances should cover. It's a national sort of mandate for that. One of the things we used to run into is if you did do a Cologuard test, that was your screening. And then sometimes the colonoscopy that followed, if it was positive, would be called diagnostic. And that was an issue where people were having large copays for the colonoscopy. But there are some new laws that passed. And so for the most part, that's no longer an issue. You might want to check if you're choosing the Cologuard test. But at the moment, I think most of those issues have been resolved.
The question is, are whole grain breads healthy for the gut? Yes. When it comes to choosing carbohydrates, grain-based foods such as breads and pasta, anything that is based on grains, whole grains is definitely better than processed or foods that are removing the fiber from it.
All right, and coming back here, if a polyp is removed during a colonoscopy and it's confirmed cancerous, what happens next? Does the surgeon need to scope again to check the margins? Is someone referred to an oncologist? So that's definitely a good question. So when we do a colonoscopy, if it is a cancer or looks like it could be a cancer, we basically either we sample, or if it's not quite there and we can remove the whole thing, we will. But then we typically will tattoo the area. So we put a little tattoo that kind of is seen on the inside, but also on the outside of the colon wall. So if it does come back as cancer, often we'll then refer you to a colorectal surgeon. A CT scan or something of that nature might be done as well. And then we can figure out if the cancer spread or it's just in that one area. The site is marked, so when the surgeon then goes to remove the cancer, they'll be able to tell exactly where it was in the colon and remove as little bit of the colon as needs to be taken out so that the whole cancer can be removed. There was one small aspect I'll say is, if you remember on those polyps I showed you, sometimes there's cancer cells in the polyp itself, but the polyp is on a stalk, and I know I've removed the whole thing because I removed the stalk aspect, and the pathologist can actually tell you if the cancer extends down to that stalk margin or does not. So sometimes I'll find cancer, but I'll have removed it completely during the colonoscopy, and you would require a sooner follow-up colonoscopy to check the area, but perhaps wouldn't need a cancer or a cancer doctor like an oncologist.
What spices or herbs would you recommend for gut health? That's a great question. So the things to consider are turmeric. This has something called curcumin in it, and that has been studied and shown to be anti-inflammatory, anti-cancer, and so that's a good one to add. Cloves. Cloves are very high in antioxidants, so that is another consideration. And things like rosemary have been shown to have anti-inflammatory properties. Ginger has been shown to have anti-inflammatory properties. So these are things that comes to my mind to kind of keep in mind when you're adding flavoring food. And this also helps to actually lower your salt when you're trying to make a meal. So if you're adding more of these herbs and spices with the flavor. So yeah.
I'll mention, just to piggyback on that, for ulcerative colitis, there's data that turmeric, or the curcumin aspect of it, can actually improve the inflammation in ulcerative colitis. I was involved in a study actually where we saw benefit from it. So there's multiple benefits for sure from turmeric. I have a specific question here. I'm 69 years old and my mother had colon cancer. Should I still stop screening at age 75? And that's a fair question. And that's what I was mentioning, that when you get to that 75 mark, it's really personalized. The age that your mother had colon cancer would be important to know. So if she had a very early colon cancer, I'd be much more concerned for you, as opposed to if your mother had colon cancer at 97 years old, your risk would not necessarily be higher. If you're a healthy 75-year-old, I would probably suggest another colonoscopy at that point. Once you get above the 80 mark, then it's really even more individualized, than the risks of doing the procedure versus the benefits we get from screening start to get close to each other. So again, I wouldn't be able to say perfectly, but I think in general, based on this, I probably would offer you one in your 70s. And once you hit the 80 mark, I might not.
So the question is, how many grams of sugar are allowed daily? So there is no particular number for this. I think it is really about it has to be, again, using Dr. Dixon's, it has to be tailored to your age, your health, where you are. I mean, if somebody, based on the age and based on the conditions and how advanced an illness they have, it'll be good to limit significantly sugar intake, right, to protect the gut. And so it actually depends upon what stage you're in. But in general, if you can find an alternative that is useful for your taste buds and your culinary reasons, like for example, dates or date syrup is a good example. if it can fix, the needs of your taste buds and your cooking needs, then I would just recommend just choosing that instead of sugar. Yeah, so there is no sugar is good in regardless of whatever level that is. That's the answer.
All right. And next question for me. Are home tests for colon cancer reliable? So that's a good test. I think when you're referring to home test, I assume it's the FIT testing and the Cologuard test. And so I think, they're pretty reliable in that, the goal that they're looking for again is that cancer detection. If you had colon cancer, they're reliably positive 92+% of the time. So I would say they're reliable in that way. There are certainly false positives. And with the Cologuard, when you get your ages are higher, somewhere in the 70s, people do release some of these DNA molecules. So we'll see some positive Cologuards in the 70+-year-old patients that turns out to be a normal colonoscopy. And I will say the one thing I want to mention just anecdotally with Cologuard, people are very anxious when they get a positive Cologuard because they assume the worst. They assume they have colon cancer. And so if you're someone who is at all that anxious type, I would recommend against the Cologuard because it's often going to take a month or so after your Cologuard test is positive for you to get in for the colonoscopy. And that's a long time thinking about it, stewing about it. So I would just say, it's not my favorite test, and certainly in the older age group, I usually recommend a colonoscopy just to avoid that possibility. We have a lot of questions for Dr. Sid. Yes. Oh, yeah.
Yeah, you can do that too. Thank you. Thank you very much. So the question is apple cider vinegar good for gut health? Everything, by the way, everything we saw in the slides, in the presentations, they are all evidence-based and backed up by data. So when we post the slides, I will have the references for the nutrition things that I mentioned. And so for apple cider vinegar, specifically for gut health, there is no robust data that I've seen. Is it harmful? No. Can it be part of a healthy meal approach? Yes. But it's not a superfood like status that I've seen in the data. So that helps.
Okay. Now, are certain shapes, sizes of polyps more prone to be precancerous and cancerous? And that's a good question. Essentially, size is, I would say, the most important. So a size greater than 1 centimeter is certainly higher risk. And those are the people that will bring back at a faster rate for their next colonoscopy if we remove it. And certain shapes, there's certain polyps that are pedunculated, so they can grow to a pretty big size. And so those ones we tend to find perhaps cancer cells in them. Those are the ones with the stalk. But in general, I would say size is the most important. Over greater than 1 centimeter is concerning. Greater than 2 centimeters or more, those are very high risk type of polyps. And so that's also a good thing to ask your family members who say, oh, I had a polyp. If they know the size, that would be really helpful because if it was a tiny little one, it really probably doesn't increase your risk. But if it's a very large one, then we almost would consider it like they had colon cancer and want you to come at an earlier screening time.
Question on the nutrition side is, are processed plant proteins like meat substitutes as bad for you as actual animal protein? And this is a great question. So I don't recommend the kind of the mock meat or the meat substitutes, and they can be used very rarely. Somebody's transitioning from eating meat, and during the transition phase, they are looking for something that has the same texture. Temporarily, that's okay. But long term, I worry about the method in which they prepared it. It's about the processing that goes in preparing those things. When you look at the animal protein and the plant protein, that protein by itself, yes, if it is made of plant protein, this fake meats, that protein will not have those interactions, the negative interactions that animal protein has, because the protein makeup of plant proteins are made of building blocks, amino acids that have not much sulfur in them, compared to animal proteins, which are made of building blocks, amino acids that are predominantly sulfur containing, like methionine. So that's more harmful. So just looking at the protein, yes, if it's made of plant protein, it's okay. However, I worry about the processing that goes into making the mock meat, the fake meat and all of that. That's my concern. So not regularly recommended, occasionally, yes.
Very good. And this question is regarding Cologuard. And if it was used instead of a colonoscopy, should I continue on the Cologuard schedule for screening? If I switch to colonoscopy, would I be eligible to screen? It's a good question that comes up. I'm going to start with the opposite. So sometimes people will get a colonoscopy, let's say at age 45, perfectly normal colonoscopy, excellent preparation, and there are no polyps. So the screening interval would then be 10 years. They, for some reason, get a FIT test 6 months later and it's positive. And then, they're sent or consulted, I'm consulted, should I do another colonoscopy? And the answer is no. So if you had a good screening test with the colonoscopy, you would follow that interval. You shouldn't repeat any stool tests in a shorter interval of time. It gets to be trickier if you've had the Cologuard test, it was negative. That was, let's say, 2 years ago, and the Cologuard screening guidelines say every 3 years, and you wanted a colonoscopy for screening. I think it's a little bit individualized based on insurance, whether they would cover that as screening. I would like it to be covered as a screening because I think a colonoscopy is a better test for polyp finding rather than cancer finding. But that might be individualized based on your insurance. So you do have to think about that a little carefully if you're going to choose one screening test or not, because sometimes it is hard to change that based on your insurance if you've already done that. The FIT test, just to clarify too, that is a yearly test. So if you chose to do the FIT test and it was negative, 1 year later, you'd be eligible again for either a colonoscopy or a FIT test again.
Yeah. Are fermented foods good for your gut health? Yes, they are. So I think I touched on that during the slides. Things like sauerkraut, kimchi, miso, and tempeh, which is a fermented tofu. All of the fermented foods favor the environment. It gives a favorable environment for the friendly bacteria to grow. So yes.
We're getting a lot of questions for nutrition. I think that's everyone's eating dinner maybe and thinking about it. Yeah. Okay, let's see. Here we go. Can you describe the types of colonoscopy prep more? Do you recommend liquid solution versus tablets? And I would say it's never exciting to do a colonoscopy prep, so none of them are perfect. I think we're getting a little better. We used to suggest what's called Go Lightly. There was a few different names for it. That was 4 liters, a gallon that you would drink at one time. Tasted salty, nasty. They put some flavoring in it, but no one loved it. And it was a lot to get down and people felt nauseous. So we've improved from that perspective. We have some newer preps. There's the Soup Prep, there's the Sue Tabs, which same ingredient. One is a tablet form, one is a liquid. And then there's ClenPick. There's multiple liquid ones. They all are pretty good actually at getting, the bowel cleans. The first step I would say is what we call the split prep is the most important, which means whichever solution or tablets you do, you want to do some the night before and some the morning of the test. And the reason why is you still make secretions. There's still more that moves through your gut, even if you're not eating during that 12 hours before your test. And so if you don't do that split prep, you might be good at midnight, but then when you get to me at 9 a.m., there's a lot of secretions in the colon. So when you do that prep again in the morning, it really makes it, sparkling clean when I look in. It's, I rate each patient based on their prep, just for our documentation. And I always like to give a gold star to certain patients when they do it perfectly. And that split is the most important. Other than that, it's based on who you are. If you're someone who prefers tablets rather than drinking a solution, you might like the tablet form called Sue Tabs. It's 24 tablets, so it's a lot to swallow. And you still do have to drink a lot of water with it, but some patients really like that. Just little tips, I would say, making it cold, whatever you choose to drink. Cold tends to be better tolerated for people. Some people feel nauseous as they start to drink it because it's a lot to drink. And for those people, I say just go a little slower, take a break, give yourself 30 minutes, and then go back to it. Try not to push yourself too hard at once. And ultimately, the goal is for your stool to look like yellow urine. Like you want your stool to look like urine is coming out of you. And if that's what it looks like, you've made it. If it still looks solid or there's chunks in it, and this is fun to talk about if you guys are eating dinner as well, you're not there, you want to give us a call and, we might have to reschedule and do it again with a different preparation. So it's somewhat individualized. If you're coming to see me, feel free to give me a call a week before and ask what's going to be best for me. But we have a lot of options. And we also have some special deals for certain of the preps because they can be expensive, the fancier ones. And for the most part, we have copay cards and things to get those to be $40 or less. So we can make it work for you, even if your insurance chooses the cheapest one, which you might not like.
Great, good to know. Yeah. The question is, do you also recommend taking psyllium? It's a ground fiber powder for gut health. Generally, it doesn't have an extra advantage over eating wholesome dietary fiber foods. So those are very rare scenarios where somebody has certain, illness that they're just coming out of, where they are not able to eat large volumes of dietary fiber food. And maybe a scoop of the psyllium could keep them going for their bowels temporarily, but they're not like long-term solutions.
That's funny. That question sort of comes into mind. So short answer, I don't mean to say the opposite, but I love psyllium. Psyllium fiber is my favorite. So just for you all out there, if you can't do all the great whole grains that's we're suggesting, I think psyllium could be a second option. But this question sort of pertains to that. I had diverticulitis last year. I eat a lot of produce, nuts, and grain. How can I avoid this in the future? And in our GI, research studies that we see, the one thing that's been shown to kind of prevent recurrent diverticulitis, this is not at the acute time period, but let's say a month later and then going forward, it's high fiber and whole grains. There is a study using psyllium fiber as a preventative for diverticulitis, and it did show some benefit. So I think, again, whole grains is your best bet. If you can't stomach it or for whatever reason, and you want to do a scoop of a fiber type, psyllium fiber seems to be, have the most research data benefit. So that's what I'm going to share today.
Thank you. Yeah, I would agree with that. I think just dietary fiber is when you're not going through an attack, in between attacks, we would say, right? That period when it's a quiet period, more dietary fiber is going to prevent the next attack of diverticulitis. So question is, do all green teas have catechins? The answer is yes. Yeah, catechins are antioxidant phytochemicals. Good stuff.
That's it for mine, so feel free to.
Okay, and then does a gluten-free diet cause problems for the immune system? So does a gluten-free diet cause problems for the immune system? No, I don't see an issue. Even for those who are not allergic to gluten, eating gluten does not cause a problem to the immune system. So, so the answer is no. Eating gluten-free does not create any problems. You don't have to if you're not allergic to gluten. Is seafood more or less harmful than red meat? So the protein that is in the seafood and in the red meat are exactly the same. The fat content, the omega-3 fats, all those surrounding accessories could be different, but the protein is the same. So the concern, doing more harm than good is the same, whether it's seafood or red meat, when it comes to the things we touched on. Do products like athletic greens help with gut health? I don't know what these athletic greens are, and if it is a kind of a juice or a powder, I doubt it. I don't know how much data there is to support those things. So generally, getting the nutrients in its whole package, in the wholesome package like this, is the best way to get the nutrients. So how do you balance a low-carb diet with eating all the grains and beans and limiting animal protein? So the question to the person who's asking the question would be to understand why the need for a low-carb diet. because low processed carb diet is there is data to support it, right? White breads and sugary things, yes, but this is wholesome carbohydrates, and having these as predominant contribution to the calories is the way to avoid colon cancer, what we talked about earlier, other types of cancers, heart health, diabetes, and all of that. So so the way to think about diet would be to think about unprocessed wholesome carbohydrates dominating the plate.
Excellent. I think that I'm going to let you.
Oh, yes. So yes, if you could not get a chance to get your questions in today, you can email, think about it, go through this and process it, and you can email the question later on to outreach@capecodhealth.org, and we will get back to you. So just a reminder that these slides will be available in a week from now at the website capecodhealth.org/colorectal-cancer. And as I said, the questions you can also post questions through the outreach email. So with that, we are closing the program today. And so thank you for tuning in. Thank you for the trust you place in Cape Cod Healthcare and allowing us to serve you. And thank you, Dr. Dickstein. It's a pleasure to visit you.
Yes.
So thank you.